Well, thank you very much for letting me join you from Italy. Buonasera, as they say here in Italy. I really enjoyed listening to the last part of the conversation. I hope that what I'm about to talk about will help. And what I'm going to share with you in the next 15 minutes is kind of the journey that medicine's currently on around rethinking, if you will, certification or its kind of cousin credentialing through training using more of a competency-based medical education model. These are my disclosures. I'm currently working for the Accreditation Council of GME, where I actually oversee something called the Milestones project. But I spent the last 9.5 years prior to joining the ACGME working in certification at the American Board of Internal Medicine. So I certainly have some perspective from both sides of the coin, so to speak. One of the things that's really driven physician training, particularly over the last 15 years in the United States with the launch of the Outcomes Project, is the recognition that the traditional training models probably weren't meeting the health needs and health system needs of the population. And this is a really, I think, wonderful article by Julia Frank and a group of international educators and authors published in December of 2010, The Lancet, that really highlights in this very nice diagram the purpose of education is really to meet those needs. And based on those needs, the competencies and outcomes of training should flow from that. And then and only then should you really think about curriculum and assessment. The one thing I don't like about this particular diagram is curriculum and assessment seem kind of decoupled when in fact they really should be tightly integrated. I'll come back to that. But traditionally in the more Flexnerian model, the curriculum has been the driver, usually developed through expert consensus, then attached to educational objectives that may or may not have been associated with robust assessment. And assessment's really been a difficult journey. We've not done a particularly good job, particularly in what's called work-based assessment. I'll come back to that. But I think the needs that all of us are now focused on, whether it's physician training, nursing training, or all the other health professions, is to meet the triple aim. And I think I heard part of that theme in the conversations in the last set of presentations, that this is really getting a lot of attention. And medical education's come under criticism, particularly from policymakers, for not doing a good enough job of preparing physicians to be able to meet this kind of triple aim. So right now, what's happening with regard to physician training is kind of an evolution of the assessment system. Most of the assessment within physician education is still professional self-regulation. I think that's a very important thing to call out. And if you look at the right-hand side of this diagram, there's really two main components. There's the accreditation component that really looks to make sure the program is providing the necessary curriculum linked to the assessment. And then there's a certification and credentialing process that really uses the individual's unit of analysis to make sure they're prepared to meet 21st century healthcare needs. Certification is something that states is theoretically still voluntary, although as noted by one of the former panelists, if you really want to work in any sort of, market-based setting, you're going to have to get certified. Credentialing is usually a local phenomenon, much like it is for nursing, where the hospitals credential, based on their needs. And the certification boards in my organization are kind of the public-facing arm, if you will, of the self-regulatory system. But what's really important is what happens inside the training program. We call our trainees residents, and those residents now have to be much more active agents to co-produce and co-create, their own competence, if you will. There's a series of assessments that's completed within the training program. Some combination of direct observation, usually audit with performance data using electronic medical record data, multi-source feedback, increasingly including the patient voice, simulation, and then the in-training exam, or the IT exam is listed here. That creates, if you will, a kind of hopefully rich data source that's then synthesized and integrated by something that's now required in the new accreditation system called the Clinical Competence Committee. And using good group process, we hope that enhances the judgment about whether the individual is ultimately ready to enter unsupervised practice. And FB stands for feedback, and this process has to include feedback both to the trainee or the learner, but also to the program, the faculty, the program directors, and others, in order to make this system work. And so we're really beginning to look at the accreditation system from a much more continuous quality improvement perspective than we have before. And what serves as kind of the framework and blueprint for the system are the milestones. And some disciplines using something called Entrustable professional activities, and I will cover each of those subsequently. So this is just to kind of show you a typical summary of the kind of evaluations our residents have gotten in the past. Typically, residents have been rated on a 9-point scale, with 1 to 3 being unsatisfactory, 4 to 6 satisfactory, and 7 to 9 superior. And then you can see that this particular resident has completed 6 rotations, and this is kind of the summary results. And so you might, imagine putting together a kind of template like this where you have the average of all the individuals within that program, kind of how they're doing. That's the average column shown here, compared against their peers. And so we could kind of walk down through this and say, okay, well, so how's this individual actually doing? So in medical knowledge, it looks like they're doing pretty well. They're about a half point higher than their peers. Everybody's rated superior, so that's encouraging. In practice-based learning and improvement, one of our 6 general competencies, it looks like they're not doing quite as well. They're about 0.2, decimal points lower than their peers. So maybe there's a problem there. And then we look at professionalism, and, well, that's kind of concerning. They're 0.6 lower than their peers, but maybe that's because they can't even spell professionalism if you look at the left-hand column there. And so the question becomes, so really, how is this resident doing? And frankly, for a lot of what's happened in medical education is kind of this phenomenon. We put people into these rotations. We work with very talented substrate, and they turn out relatively well. But the middle step here, this, miracle occurs, really something that we haven't done a very good job of providing more robust feedback in making sure people can really attain the outcomes we hope that they'll attain. And so that's led to this concept of using these things called milestones. And that's simply a significant point in development. This is an example of a milestone in England, kind of showing the direction in 2 ways. I just want to point out it's not meant to be a tombstone. It's a milestone. And milestones should enable the resident, fellow, and others to better determine an individual's trajectory of competency acquisition, so that we look at it from a very developmental process, and are there kind of stepping stones or milestones along the way that can help guide the individual in making sure that they're attaining the competencies they need for unsupervised practice. So this is the kind of general template, if you will, that's currently being used in graduate medical education. The milestones are kind of depicted in 5 different levels. And if you look at the anatomy of what the milestones look like, we have the kind of overarching competency. In this case, PC stands for patient care. The sub-competency in this case is, can they take an appropriate history, based on age and impairment? And then the milestones are really the words that describe the developmental levels. Now, in this system, the goal for most of our residents or fellows is to reach level 4 prior to graduation. That's not to say that they may reach level 4 in every sub-competency, but that's the target. Level 5, theoretically, is designed to be more aspirational, and for those who don't reach it during training, it gives them kind of a next way station that they should be shooting for when they enter practice. The other thing that's kind of deliberate in this model is there are no words like satisfactory or unsatisfactory, and that there are mechanisms that allow the program directors to basically say, we think the individual's in transition, that they're between level 3 and 4, and that they meet all the level 3 kind of descriptors, but they're not quite at level 4, and so there is the opportunity to acknowledge that kind of transitional state. The other concept that's being increasingly used to determine somebody's kind of, status for certification or credentialing is called the Entrustable professional activity. This was developed by Ola Tencut and Fedashila in Holland. And EPAs represent the routine professional life activities of physicians based on their specialty and subspecialty. The concept of Entrustable, I think, is really important, and I think it was alluded to in many ways in the last conversation. What it basically means is that the practitioner has demonstrated the necessary knowledge, skills, and attitudes to be trusted to perform this activity unsupervised. That's not to say independent, but unsupervised, that they can work well within a team and that the roles that they're expected to perform they can do without ongoing direct supervision. And we make a lot of entrustments in medicine, but too often those entrustments have been made on what we call time proxies. Oh, you finished your internship? You must be able now to lead a team because of that. In reality, we know from research that's not always the case, and these concepts of milestones and EPAs now allow us to at least have a common language to really think about, did the individual meet that particular milestone? Are they really ready for the next stage? Now, these are not pure concepts. They're all interrelated. This is one way to think about how these fit together. Entrustable activities, because they tend to represent the more synthetic activities of a professional. I'm a general internist by training, so for me, an entrustable professional activity is being able to manage a population of patients with complex multiple comorbidities. You know, how do I manage that patient that's got congestive heart failure, diabetes, hypertension, where you have to make trade-offs and manage a lot of, medication. Within each of those entrustable activities are a series of competencies that enable me to be able to perform that EPA. I have to have good communication skills. I need good clinical skills. I also need to do good care coordination. These are all competencies, and they're developmental milestones that help me during my structured training, be able to manage those kind of patients by, linking all of those together. So milestones and EPAs within kind of physician training right now are seen as kind of a roadmap, if you will. And we recognize that the journey is not a straight line. So somebody alluded to earlier that depending on where you are and what your role is needed within that system, you might be doing different things. And I think this is part of what's brought into this concept is that depending on the context, the journey is going to look a little different. That there are more than one path, but the number of paths are not infinite. And so that's the challenge here is what's kind of acceptable and what's not. And it really is trying to address the problem of if you don't know where you're going, any road will get you there. And so trying to define in more words and descriptive narrative what the outcomes are is our attempt to try to help program directors think about what their curriculum and assessment should look like. Now, these milestones are based on, as I said, a developmental model, and one of the models that's heavily influenced the development of milestones is the Dreyfus brothers developmental model, where you move from kind of novice through advanced beginner, competent, proficient, then hopefully become an expert or a master. We fully recognize that this journey is not a straight line, that it will, have some ups and downs. Some trainees may actually regress. Our hope is the milestones will allow people to pick up when that happens so they can intervene and do the remediation. We also know, as I alluded to earlier, people have different paths or may progress at different rates. And so this individual in green, you would want to adjust their curriculum to allow them to advance at a faster rate so that they don't experience what Anders Ericsson calls arrested development, where we make them an experienced non-expert because they keep doing the same thing and are not challenged. On the other hand, the individual on the red trajectory below is not going to make it. Despite multiple interventions, they're just not destined to be a physician. They're just not going to have the competencies needed. It would be really nice to identify that earlier in practice to make those hard decisions so that we don't continually pass them through. And so in the end, what this looks like is we need much more integrated curriculum with assessment to really help make determinations when, people are moving along this trajectory, if they're on the right line, so to speak, or at least the minimal line. And so the milestones are hopefully a roadmap and a blueprint to help programs, attempt that. Now, when we look at assessment processes, these are a couple of things we also are spending a fair amount of attention with this kind of transformation. One of the things we know that one of the most important components of the curriculum is the actual clinical care they provide and experience during their training. So having clarity in the right outcomes that's linked to that curricular experience is really essential. And we have to make sure that the educational systems are integrated with the clinical system. because growing research shows that the clinical system is not providing high-quality care. The trainees get that imprinting and will often carry that suboptimal care with them out into unsupervised practice. So we need the right combination and synthesis of these assessment methods. And the other thing we've learned from assessment, although it doesn't solve all problems, but one of the things that's really important is having a shared mental model of what competence actually looks like. And again, I heard that in the question and answer period during the last session. In competencies, milestones, and trustful professional activities, which target different components of the system, are designed to help enhance the understanding of the mental model of what it is we hope will come out of the training system. With regard to assessment, these are improvements I think we can implement now, and I don't think there's any substitute for this during training from an assessment perspective. Observe, observe, observe. There's no substitute for ongoing observation and feedback from an expert clinician. Lots of research has shown the importance of that. The other thing that I think is really interesting is that there's been this intense effort in medicine for decades to find the holy grail of assessment forms. They don't exist. The assessment form is only as good as the individual using them. It is important to get the form right, but after that, it's really about the individual who's making the judgment. And one of the things that we've learned recently is that you need to align the assessment forms with the purpose and construct of the assessment and curriculum. So if you want to think about a developmental process, the assessment form itself should look developmental. It shouldn't look like the form I showed you earlier. You know, is this resident superior? Superior compared to what? It should be more of a developmental construct. Are they ready for unsupervised practice to make much more sense? You have to invest in assessor development. For credentialing, as important as certification and testing is, I spent, as I said, a lot of time in the certification environment. The most important piece of the training system is what happens inside the training program. That by far and away is the primary determinant of how people are going to turn out. So moving forward, we're going to have to be much better with regards to work-based assessments. I heard that with regards to electronic medical records, but things like direct observation, patient surveys, multi-source feedback are things we're going to have to get better at. And the local assessment practices really need to be seen as a continuous quality improvement activity locally so that you're constantly getting better through these processes. So I think the next steps are really the work that we're thinking a lot about is looking at these work-based assessment methods around interprofessional team care. How do health practitioners use clinical decision support? Given the amount of knowledge now, it makes it impossible for you to carry everything on your hard drive. You're going to have to become very fast on using clinical decision support. Quality, systems-based practice, and safety are critical skills that don't get picked up very well in our traditional assessment methods, such as multiple choice questions. And communication is really being recognized as a very sophisticated competency or skill that needs a lot of training and we have to do a better job of assessing it. We also need to embed work-based assessment into our routine clinical work. And electronic medical records will need to evolve to make this easier and create these robust and longitudinal, ongoing real-time feedback loops. So let me stop there, and I'll turn it over to the panel. I look forward to the question and answer period. Thank you.
Thank you, Eric. And as we've done before, if you have questions, jot them down on a card, and we'll take the Q&A after each of our speakers have had a chance to talk. Our next speaker is Jody Frost, who's the lead academic affairs specialist and program director of the Credentialed Education Leadership Institute Fellowship at the American Physical Therapy Association. Jody?
Thank you.